Thanks everyone for coming along. So I'd like to welcome everyone to this, which is the final in our Trinity Term series of non-technology webinars. I'm going to hand over to Nisha, who's going to introduce our speaker in a moment. I just want to do a little bit of housekeeping. So at the end of the presentation, there will be a Q&A. We operate this in two ways. So first of all, you can turn your camera on and raise your hand, either physically, or you can use the little icon to raise your hand if you would like to ask a question. Or if you prefer not to speak or turn your camera on, you can type a question into the chat and I will go through the questions in the chat and try and read those out for Melanie to answer. So I think that's all fairly clear. Without further ado, then I will hand over to Nisha.
Brilliant. Thank you, Michael. And thank you all for joining us today for Dr. Melanie Smallman's talk. It's titled, Why We Need a Sociological Approach to the Ethics of AI in Healthcare at Different Scales. Dr. Smallman is a lecturer at UCL and Turing Fellow as well. Her research in the field of science and technology studies centers on the social acceptance of novel technologies relative to how responsible and ethical these are, with a key focus on the effect technologies have on inequalities and their wider social impact. Prior to her current roles, Dr. Smallman was a fellow in STS at the Harvard Kennedy School for Government. She was also a UK government advisor and a science policy consultant at Think Now. So we are very delighted to have her here today to discuss how multi-scale ethical frameworks can help to address the ethical issues surrounding AI in healthcare. And we can all appreciate that that's a set of technologies that we're seeing fast growth globally. So without further ado, I'd like to invite Dr. Smallman to begin her talk.
Great. Well, thank you. And thank you very much for inviting me, first of all. I'm only sorry that it's not in the flash, but I'm sure we can cope. So I'm just going to share my screen again, and hopefully it'll be, is that visible now, my PowerPoint? Great.
Yes.
And nothing else. I'm not sharing any other secrets, I hope.
No.
I learned the hard way with sharing with students this term. So, yeah, I'm going to talk about some work that I have been doing over the past few years, and which at this point I'm kind of trying to test and develop a bit more, and just thinking a bit about how we think about ethics regarding AI, because I think that it's an increasingly sort of pressing and prescient issue. So I want to talk to begin with about this photograph, and it's, I mean, the way I came to this topic is partly because of this photograph. It's a slightly long story, but this is a photograph of my neighbours, and in, I think it was 2018, a group of residents in Hammersmith and Fulham, people that I live amongst, some of them my friends, staged what they called a die-in. So these are people lying on the town square in Hammersmith with bandages and fake ailments, pretending that they're all dead in protest of something that was going on in the NHS. And what's kind of interesting, so these T-shirts that you can see, the man in the middle and the woman in the foreground, they say Save Charing Cross Hospital. So these are pro-NHS campaigners who on a Saturday afternoon had thrown themselves on the town square, on the pavement, to protest against what was the first implementation of AI in the NHS. So they're protesting against the GP at hand app. And, you know, this at the same time, literally 2 or 3 weeks later, Matt Hancock, the then Secretary of State for Health, talked about AI in the NHS and said, now's the moment to put failures of the past behind us, to set our sights on the NHS being the most cutting-edge system in the world for the use of technology to improve our health make our lives easier and make money go further, harnessing the amazing explosion of innovation and the connection of billions of minds through digital technology that has brought to this world. So, I was really struck by this juxtaposition of this big talk from the Secretary of State for Health and this massive commitment to put the NHS in the hands of technology, because this technology would give us better medicine, improve our health, make our lives easier, and save money for the NHS. Yet my neighbours were throwing themselves on the pavement to say no to this very same vision that the Secretary of State is painting. So I had to think, what's going on here? As somebody who studies the sociology of technology and who's involved with data ethics, what's going on here? What are we missing in data ethics that's allowing this view to flourish, yet my neighbours to feel so compelled to protest? And I'm going to talk a bit afterwards about what part of the reason that I think this is happening is some work that I did much earlier, where I was looking at public and elite, so scientists and politicians' attitudes to science. And what I found was that they did not share the same view of science, and that at the heart of sort of policy and politicians and scientists' views is what I called science to the rescue. So this vision of science that science solves problems, that's what it does, that the downsides are unexpected or unfortunate side effects that we can actually tackle with more knowledge and more technology, and that the risks that come from new technologies are in many ways knowable, quantifiable, and manageable. And I think for me, the tension here is with this socio-technical imaginary of science to the rescue with how people experience technology. So I'm going to say a bit more about that, and I'll come back to this. Yes, so this is just another picture, another view of the people. And I think it's poignant. We can see in their faces the kind of people who are here protesting against this technology. GP at hand, not on my land. GP at hand should be banned. They feel, really strongly that this is a technology that shouldn't be in the NHS. So what on earth is happening? Round about the same time as this was happening, and the statements that the Secretary of State was making about how the technology, how AI and digital technologies are going to save the NHS in some ways, there's been a massive growth in both investment in AI, but that has been coupled with frameworks for ethical AI. So this is just sort of a snapshot of some of the ones that they're the main ones actually that I've been looking at. So the first piece of work I did was reviewing what these guidelines are about. So what is it that the ethics guidelines that exist at the moment think are worrying about AI, and what are the ethical concerns? And they all center around these 5 ideas around transparency, justice and fairness, non-maleficence, I think I find that a hard word to say, responsibility and accountability, and privacy. And so, yeah, we've got these multiple AI ethics guidelines that are circling around these terms, yet clearly they don't capture everything that my neighbours are worried about. So I started thinking about what's missing here and what are we not quite getting right. And what my neighbours were protesting about, this was a quote from one of the residents who spoke to one of the health service publications who were reporting on these protests. And one of the residents said, they're taking NHS money away from GP surgeries who need it to take care of the old and the sick. This is bad news for everyone except GP at hand. So none of these protests were about privacy, about transparency. Possibly this is an issue of fairness and justice, but there's something which the current ethics guidelines were not getting at. What they're concerned about is the shape of the NHS changing under their noses without them being spoken to, without them having a stake in it. And so in particular, the story, I mean, this bottom headline, extended hours cuts linked to GP at hand threatens practice closures. Basically, what has happened in Hammersmith and Fulham, where I live at the time, is for fairly complex reasons, but directly related to the app, the local area health service ran up a massive deficit, and as a result closed all primary care services, so all evening and weekend GP appointments were ended. So there was the gist of it was that people from outside Hammersmith and Fulham, young people who liked apps, were registering with Hammersmith and Fulham GPs and sucking resources out of the local health service. And that was taking resources away from older local people. So there's a massive issue. It's sure it's an issue of justice and fairness, but actually, more significantly than that, it was an issue about the shape of the NHS, which lots of people have pushed back on me. Technologists have said, well, we just need to change how budgeting within the NHS works to accommodate this. But, you know, a decision to employ a technology is changing the shape of the NHS, which is normally a process which is under democratic control, democratic scrutiny, and my local residents, those campaigners, would have an active role in shaping. So a seemingly technical decision was actually a very, very significant democratic and political decision, which is why they were throwing themselves on the street. And so, you know, the question to me comes to, how can we have missed this? How can we have missed those concerns? How can this technology have slipped through all of the ethics checks to such an extent that people feel this strongly about it? And in the literature, so Hagendorf has written about this, arguing that almost no guidelines talk about AI in context of care, nature, help, welfare, social responsibility, or the sense that they belong in networks. So in AI ethics, technical artifacts are primarily seen as single isolated entities that you can optimize to find technological solutions for technical problems, but they actually work in a wider world. And so they argue that what's missing is this consideration of wider context, which I absolutely wholeheartedly agree with. And so to take another trip, just this is again another picture, different view of my neighbourhood. I don't know if anyone knows London, but this is the bottom of the A40, so the main road from Oxford into London. The little corner at the bottom, the red triangle at the bottom of the screen, is where I play tennis on a Saturday. And I think this is, you know, I find this quite a symbolic picture to me, because I think if you think about the cars in this photograph as a mode of transport or a way of carrying people from A to B, that is how we're thinking about AI in ethical terms at the moment, that it's a tool to solving problems. And it's true, a car is a way of getting people from A to B, but just look at that photograph and how my neighbourhood has been shaped, bisected, structured around the needs of the car. It doesn't take more than a few seconds to understand that in terms of an account of the impact of motor vehicles, cars, on our lives in the 20th century, to describe it as a way of getting from A to B, or to think about it in those terms, is really not a sufficient description. And for me, that's how we need to start thinking about AI and digital technologies, is not as tools or instruments from getting from A to B, but as technologies that are structuring our lives and our worlds in very concrete but very, very profound ways. And I think the challenge is to then start thinking about what the ethical considerations might be when you stop worrying about the space between the technology and the user, or the technology, the caregiver and the user, and really start thinking about these social structures and institutions and how they're being affected by these technologies, suddenly a whole different scale of question and concern appears. So yeah, that's what I have already written about.
Deeper allows you to have freedom of expression. If you don't, what you'll do is you'll just have loads of...
Is that me? No, okay. That sounded more thoughtful than me, but it's not me. Yeah, so I think my argument has been that traditional approaches to data ethics has, assumed technologies in healthcare are like drugs, or they function like cars or solutions, that the concerns are between the technology and the user, or the patient and the practitioner, very heavily focused on individual rights, and assumes, and the reason, I mean, there's a good reason why these things are so. Data ethics has largely come out of biomedical ethics and bioethics, which has a very long tradition of coming out of the history of shocking incidents across Europe in the 20th century. So that focus on protecting rights against the state has a worthy history. My challenge is that I think perhaps we need to think beyond that now when it comes to these digital technologies, and we can't assume that do no harm is the same as socially beneficial. And to me, these much wider sociological issues have just been very seriously neglected. And so, as a result, the current guidelines are following the science to the rescue imaginary, assuming that goods automatically fall out from technologies and that the risks are manageable and quantifiable and governable in some way, which, I'll explain in a second, some instances is just not a reasonable way to be thinking about this. So all of the guidelines that I've looked at, the assumption is that AI in healthcare is a beneficial development. There's very few questions about whether this could be non-ideal or problematic. The downsides that current guidelines have flagged up are things about increased demand for service, the potential for two-tier health service and growing health inequalities. What's particularly interesting is that the assumption in all of these is that if there is a two-tier system, the haves, the rich people, are the ones who have access to the digital technologies and the AI. The poor people are the ones who get the face-to-face service, which is a very, very interesting assumption in light of the kickback that's happening at the moment with GP surgeries, the pressure they're coming under to offer face-to-face services again. It's pretty clear that the digital service is not the premium service. It's likely that they've got this understanding the wrong way round, and that it's going to be the have-nots that are lumbered with the technology rather than the haves. And the assumption as well in the guidelines, really importantly, is that these ethical issues all can be addressed. So any downsides can be tackled, and often they can be tackled with more or different technology. And the idea is that AI, ethical AI, is possible, and that's what we're working towards. I would say that that's questionable, and we'll say a bit more about that now. I think that I have said most of this. Just a couple more of these points that I haven't touched upon is the current guidelines. Mostly the group effects are seen as an accumulation of individual effects. There's no possibility considered that technologies can, that the effects of technologies can actually be new, or they could be sort of systemic effects or cumulative effects that are more than just the impact on a group of individuals. So something about it being systemic is not quite understood. And impacts on institutions tend to be focused on discussion of what's needed to accommodate these technologies, rather than any impact on sort of wider social democratic structures. So what's made possible and what's not made possible isn't really considered in these guidelines. And interestingly, the financial implications of advanced technologies on healthcare are typically seen in positive, well, not typically, almost exclusively seen in positive terms, in the sense of the potential to reduce costs or to exploit data. And I think that is also, as I'll say a bit more about, a very problematic assumption with actually fairly shaky evidence to back it up. And so, you know, what I've been thinking about and arguing is that I think the current guidelines are just very flat. They're looking at individuals and looking at rights, when these technologies are much more, they're structuring things, and I think we need much more of a topography to think about them in a much more topographical or textured or richer way, deeper way. That's a good word if we're talking about topography. We can't go on with this flat understanding of how these technologies work. It needs much, much more texture and depth to it, which is starting to get me to think about scale. So a few of the things that I've been thinking about that's leading me here. So firstly, you know, taking a rights-based approach to ethics is understandable, but the NHS has never been based on the rights of individuals. So from the start, collectivity and group effects have been taken into account and have been really at the founding heart of the National Health Service in the UK. And even now, so things like the National Institute for Health and Clinical Excellence, who make decisions about which drugs are allowed to be prescribed through the NHS, that's not made on an individual basis. That's made on a collective cost versus benefit basis. And similarly, you know, the move to vaccines, that was not an individual. I mean, in the end, people had individual rights, but the whole way vaccinations work is not based on simply the benefits for the individual. It's about herd immunity. So collectivity and group effects are missing from current guidelines, but are really, really important for the operation of the NHS from its birth. Secondly, you know, this idea that technologies, that the downsides can be managed or governed and, you know, made to disappear in some way is so problematic, because we know that the downsides of most of these technologies are baked in, or as some people say, they're not glitches, they're features. So one example that some colleagues of mine in another department at UCL have been looking at is the role of the job that these smart home things like Alexa, or I can't remember what the other one's called, you know, those things that speak to you. I don't have one. The role that they're playing in the continuing or allowing perpetrators of domestic abuse to continue to abuse their partners. So one of the features of these devices is that they're ambiguous. When, I don't know if anyone's got one, but I'm told when you get one, it doesn't come with an instruction manual. You get to know it by using it. And part of the reason for that is that actually they don't do very much. They have the potential to do more, and they do more as you interact with them and as you download new upgrades. But that ambiguity is part of the charm and part of the selling point of these technologies. Yet that's the very thing which people, perpetrators of domestic violence, my colleagues have found, are exploiting in order to continue to harm their partners. For instance, by making up imaginary situations where the Alexa system is monitoring them. So you'd better not leave the house because Alexa will know. You'd better make sure that you're hoovering properly because the Alexa knows how many hours you've been doing housework and so forth. So, you know, this isn't an accidental downside of this technology. This is an exploitation of the very feature that is the charm of these technologies. And similarly, I mean, in 2019, 9 scientists wrote a big letter in Scientific American posing the question, will democracy survive big data and artificial intelligence? And they argue that if you couple the uncertainty that I've just described of these advanced technologies with a lack of transparency and insufficient democratic control, then you have a toxic situation where you have the potential to destroy social cohesion, increase conflict, as different groups stay within little information bubbles and no longer are able to relate or even understand the perspectives of other people. So, this ambiguity is part of the technology, and that's the dangerous aspect of it. So this is not something we can manage away. And is that secondly or thirdly? I feel like I've skipped something, but the technologies are shaping the systems in particular ways. So just like I showed the picture of the car that, my part of West London that's been physically structured to accommodate the cars, so too are institutions like the NHS. So some colleagues of mine at King's have been looking at robots in healthcare. And so there's a big push for robots to be bought in the NHS to operate on prostate cancer. So all of the clinical evidence is that a robot is better than a bad surgeon, but only as good as a good surgeon and not as good as an excellent surgeon. So clinically, these are not really doing anything that a good surgeon and good training couldn't do. Yet the cost of them is shaping healthcare in a particular way. So community radiation services are being withdrawn, and treatment for prostate cancer is being concentrated around big teaching hospitals. So people in low incomes who don't live in the big cities, who find it harder to travel, already have worse prognosis from cancer diagnosis just for the other social conditions they have, but they're now being asked to travel further or forego care because a decision to purchase a technology has been made. And again, this is going back to my neighbour's point, is that this is a democratic decision. This is a decision that should be subject to democratic decision making and scrutiny. What shape of healthcare do we deliver? Local services, or do we centralise healthcare in big teaching hospitals? And it's being disguised and hidden as technological decisions. So technologies are shaping systems in particular ways and occluding those decisions from public scrutiny. Yeah, exactly what I was saying. And even, another instance is some work that Lupton has been doing, looking at health apps and arguing that I've got one on my wrist now, so I'm feeling a bit embarrassed talking about it, that these quantified self apps are changing what's considered to be a good patient. So while once it was taking care of yourself, eating healthily and not being overweight and showing up for checkups, with a digitally engaged citizen, these data apps are now meaning that a good patient is somebody, firstly, who does quantify themselves, who measures and keeps an eye on blood pressure, sleeping patterns, and so forth. But even beyond that, the good patient is now one who's prepared to share that data and to give information about themselves so that others can either measure themselves against it or even, for research purposes. So, it's the ideal patient has shifted from somebody who just engages with the healthcare system and looks after themselves to being a willing data subject, which really kind of shapes and changes what we mean by a patient, I think, in pretty profound and significant ways. And I think, this is particularly problematic for the reasons I've just given for the UK, for countries where we have a nationalised healthcare system that is functioning within a democratic state. And I think, fourthly, this is sort of coming back to my background in science and technology studies. We've known for a long time that the benefits of technologies are not shared equally or at the same scale. And I think I don't know if people are familiar with these books, they're kind of, those borderline books between being academic texts and public, so they're very readable. But Virginia Eubank's book, Automating Inequality, talks about, she goes into a number of social welfare situations in the US and looks at how AI and predictive technologies are being used and what effect they're having on the recipients of the benefits. And the conclusion she comes to is that automated systems control which neighborhoods get policed, which families attain needed resources, and who is investigated for fraud. And while we all live under this new regime of data analysis, the most invasive and punitive systems are aimed at the poor. And this is deliberate. This is her argument, is that this is not an accident. This is deliberate. And she goes as far as to say that people on low incomes needing benefits in the US live in a level of surveillance that most middle-class people would find utterly intolerable, yet they have to submit themselves to that in order to receive basic services for survival. It's a great book. If you haven't read it, I recommend it if you want a good chill. Similarly, Ruha Benjamin's book, Race After Technology, highlights how particular racial groups are heavily overrepresented in certain data sets and have more frequent engagement with a number of data-driven algorithms, not necessarily ones which they benefit from or for positive reasons. So typically, you know, it may be law enforcement data or things where the Black communities are being their privacy is being massively invaded, and they're not experiencing any benefits from that. The benefits are going to other community groups outside theirs. So the benefits and risks are not shared equally. And overlaid upon that, we also know that digital technologies are driving inequality, which in turn drives ill health. So we're getting this nasty cycle of inequality. The thing which is supposed to be curing illness is driving inequality, which is in turn driving more ill health. So, I mean, Cousin's work from back in 2002, talking about how innovation policies and advanced technologies tend to increase wage equality by, rewarding the higher end of the job market and eliminating jobs and security in the middle and bottom of the market. So, more polarization of the economy happening. Brynjolfsson and McAfee, who are both economists at MIT, have argued that in the past 20 years with digital technology, while we've seen the overall pie of the economy growing, some people, and arguably a majority, are even worse off by advances in technology. So the benefits of that growth are being felt much more by those at the high end of the market and who own the technologies rather than the workers, which is accounting for at least part of that polarization that we're seeing in advanced economies over the last 20 years. And then Kondo's work about people living in regions with high income inequality have an excess risk of premature mortality and death. So if you have the thing that's so interesting about this is whenever I talk to my students about it, they assume that they're going to be in the high end of the income. But in an unequal society, even the high earners have worse health outcomes. So everybody loses in a high income inequality world. So it's a complex mess. So bringing this together, I've been thinking about how the impact of technologies at kind of systems, institution, community levels, they clearly matter for the affordability, the shape, the acceptability of the NHS, and for the long-term health of the population. And that these ideas around collectivity and group effects really, really matter for the NHS. And so my question has been, how do we build these kind of issues into ethical frameworks for evaluating AI? And again, going back to this idea of topography and scale, I've been thinking about how the impact of things like the GP at Hand app, it clearly varies depending on the position from which you view it. So, let's be fair to this technology. If you're a time-pressed individual, like perhaps most of us, the app's really great because you can have a GP consultation online, answering some questions without leaving your home or office, and that's fantastic. But to my community, it's causing a withdrawal of face-to-face services and raising concerns about fairness and fair access to service. For the NHS locally, it's a question about affordability and the appropriateness of a kind of geographical approach to budgeting. If services can be provided to everyone, anywhere, anytime, how is this going to work? It also opens up on a national level, really significant debates about the privatization of NHS services and how it's funded. So, this is not money that's staying in the NHS that's paying doctors and nurses. This is millions of pounds that are going into the private sector. So those decisions to buy technologies are also decisions to buy into the private sector, and we haven't actually had that debate. And there are significant issues about intergenerational fairness, the long-term sustainability, so technologies that are energy heavy, what are we doing when we make these decisions? All of these need to be taken into account, in my view, when we're making ethical evaluations of whether or not technology should be applied in a healthcare situation. So I've been working on this idea, which is now impossible to read because that's so small, of building a framework that we've called multi-scale ethics, that forces us to think at different levels. And so what you probably can't see are some questions posed. So rather than, I'm not a philosopher, so I don't come up with normative statements. So rather than explaining what an ethical AI system would look like on a group level or a systems level, we're posing questions to think about what the effects could be on those different scales, to help us zoom in on where the ethical concerns need to be, where we need to pay attention, at what level do we need to pay attention, or even to just say, well, we can live with those consequences. That's the price worth paying to have this technology. But to provide some kind of structuring device that's reasonably simple and straightforward, to help us think through these issues that go beyond those basic questions about individual rights and privacy and so forth. And I think that's where I was going to leave it, really. I've got more to say about, let me just see if there was more to say. Yeah, there's some more, I guess, to say growing in the future about, we've been testing this on COVID, and there's some interesting things have been coming out that we're just in the process of processing. But yeah, that's where I just want to leave it, is the proposition that we need to start thinking about scale when we're thinking about ethics. Otherwise, we're going to miss the really important points which are driving residents and citizens to throw themselves on the street already in protest against these technologies that are supposed to be there to rescue us. I feel like I've said a lot and very quickly, so hopefully that was coherent.
Well, that was brilliant. Thank you very much, Melanie. So if everyone would just, first of all, just like to join me in showing their appreciation. If you don't particularly want to clap out, you can use the little...
You can put your thumbs down.
any thumbs down, you'll be kicked out. Thank you. So I guess we will now move on to the questions. We do actually have a question that Miranda posted earlier in the chat, so I'm going to start by reading that out, and hopefully that will give everyone else a few moments to think about drafting. Okay, we've already got our second question, so some people are really on the ball. So I will start with Miranda's question. Miranda sadly had to leave, but she said, really fascinating, thank you. Just low, but she liked the analogy with the car as a technology with impacts beyond the individual. I wondered whether it makes a difference that restructuring via AI may often be less visible than the development of road networks.
Yeah.
For that reason, transparency is important after all, but a systemic form of transparency with communities and democratic systems, and not just communication about individual rights.
Yes. Exactly. Yeah. I mean, I think that's a really good point about the transparency and the visibility. I mean, yeah. And Yeah, I agree that the invisibility is significant, and perhaps that's why it is not being thought about when it should, because at the moment these effects seem to appear, oh, we didn't expect that, that's a surprise. But I mean, I guess in some ways when people, I mean, I'm no historian, I guess in some ways when the car was being developed, they didn't anticipate that they would cut through West London and build this massive weird roundabout. But yeah, it was pretty obvious to the people living around them when that was being built that was happening. So yeah, I think that's an interesting point. Thank you.
I mean, I think so. We have more questions, but I'm just going to follow up on that briefly since Miranda's not here. I suppose there is a difference that a road, as you mentioned, is a public utility. It's very easy to see when a road is being built. And we do have protests against certain roads and sometimes railways and tunnels, cross being built. We don't necessarily always succeed in stopping that being built. Do you think it's different because so much of AI is owned and governed by the private sector, and they can claim either intellectual property rights or trade secrets, corporate rights to secrecy, to not disclose some of those larger structural elements, such as, for example, where data is going and how it's going to be used in future? Whereas it's a lot harder to pretend. You can't not disclose where a road is going or how many it's going to be.
Yeah, I mean, I think even the roads is an oversimplification of, I mean, this is my fault because that's what I talked about in the picture, but, you know, we just look at the food that's on the supermarket shelves at the moment, or what isn't on the supermarket shelves, to understand that the meals we have each evening is dictated by the automobiles, right? So if you can't drive the food to the supermarkets, it's not on the shelves and we don't eat it. Who you hang out with at the weekends, if you meet somebody, they're all right, but you can't be bothered to get 2 trains, or, you know, the effects of these technologies is really very profound and affecting really subtle decisions. So even just the road analogy is an oversimplification that I've made. But in terms of I mean, I've got a lot to say about the private ownership of this. And I think, first and foremost, the really simple thing is that money is going out to the NHS. So when you pay doctors and nurses, they pay tax and national insurance, which goes into the Treasury, which comes back to the NHS. When you pay a private technology company, they're very good at avoiding paying that tax. And they certainly don't pay the same amount of tax as a doctor and nurse would. So there's a net flood out of the NHS. If you pay the same amount to a private tech company as you do to staff, the economy has got less money to reinvest in the NHS. And that is a really, really worrying and serious thing. So even before we get into the details of the technology and who owns what, there's something very, very, very troubling about that decision to buy that, because it means that in 1, 2, 3 generations, you won't be able to do that again. So, yeah, and in terms of the data, I mean, where to begin about who owns the data? It was ours in the first place. It's yes, it's all worrying.
Okay, well, on that note, I will move on to other people's questions. So Elizabeth asks, as an advisor to health tech innovation centers, primarily in the US, I've seen a shocking lack of interest from funders and venture capitalists in designing for people with different histories, backgrounds, and commitments. It is seemingly something that developers cannot or will not, or perhaps lack the knowledge of how to modulate. How do we address the funder mindset or capacity build for developers in the technology-driven privatization of services using a multi-scale ethics framework?
Yeah, that's a very good question. So I'm not sure my framework could help, couldn't it? Because we would have to then start thinking about who the groups are that are left out or overrepresented, what that means, and actually force the developers, I mean, force, that's a strong word, isn't it? It's help the developers maybe to just understand that the effects that they're having are not necessarily the effects they think they have. I mean, I teach responsible research and innovation and to engineers at UCL, and every year the British Museum is down the road from me, and we go to the British Museum and we have a look around the gallery, and I say to them, so look around the gallery, I'm going to leave you for 15 minutes and I'll meet you back in the classroom, and when you get back I want you to tell me what the most useful object is in the gallery. And they come back and I say, I'll hang around if you've got any questions. So I hang around, nobody ever asks me anything, go back to the classroom, and they all say what they thought was the most useful object. And I always say, oh, that's really interesting, because I was thinking what the most useful object would be for a child, but none of you asked me who it was useful for. You all assumed that if it was useful for you, it was the most useful object. And I think, to me, it's about talking about this from the word go, is understanding that the developer's perspective is not the only perspective, and that, you know, you need to have wider input to be shaping this in the right way. I mean, I guess what's kind of interesting to me is whether it will change when technologies are being developed for nationalised healthcare, because you can't have an app in the NHS that only serves people who can afford to pay for it. I mean, in the US, you can imagine healthcare insurers buying into particular technologies and having them as a selling point to attract people, but that simply can't work in a nationalised healthcare service. So I would be kind of interested, you know, in my utopian world, perhaps there is a difference in people developing it here as there. I suspect not. I suspect they're the same people and the same technologies. But, you know, and the other option would be to have different models of technology development. So I'm really interested in the cooperative technology movement, so tech co-ops. But also, you know, why isn't the NHS developing these things? They say they are, so perhaps I'm wrong. They have the data, bring in the people in-house and develop it internally, don't pull the money out.
Thanks. So we have, I think this is more of a comment from Carmela, but if I have misinterpreted that, please either add more data or feel free to turn your sound on and speak. But Carmela says, glad to hear one of your early slides that ethics principles are similar, the same as in clinical research, and follow the same research integrity principles. I'm not sure that you were necessarily suggesting that's a good thing. I think you were suggesting that's a weakness, because clinical ethics and biomedical ethics tends to focus very much on the individual and on individual autonomy.
Exactly.
And actually, I think in this situation, individual autonomy is not the biggest problem.
Exactly. I'm not saying we should discard that. I think that there's important reasons why biomedical ethics are as they are. But I think we're talking about something bigger here, and that we need to lift our heads up and understand that. Otherwise, we're going to be getting in quite hot water quickly, just by not realizing that the effects of these technologies are not the same as the effects of drugs.
I mean, there does actually, just thinking more widely, there does seem to be a tendency for, you know, the quote unquote ethics of technology, when people are thinking about any new technology, to look to the medical ethics simply because it's there and it provides established tools. And I guess as well, academics who can come in and say, well, I've written about, you know, the ethics of end-of-life care or organ transplantation, so yeah, I might as well have a go at driverless cars, or I might as well have something to say about, you know, and actually maybe that's not a good thing, or at least maybe it's a limiting thing.
I mean, I think that's my point, is that it's a limiting thing. It's not a bad starting point, though, is it? Because to be fair to biomedical ethics it is effective and has been valuable, and addresses significant problems of concern. But I think there's new things coming in that need to be added to it, not just. And I think there's an element of disciplinarity about it as well. Is that most of the people who've been writing about. So most of the people who've been involved with writing ethical frameworks for AI are philosophers, and some of my best friends are philosophers, but there are more perspectives than that. And I think that this is why I'm particularly interested in this project, to be honest, is that it's a chance to work with my lovely philosopher friends and to show that sociological perspectives are also useful, not just, I think we've got a bad reputation of just describing things. And I think here, describing things and anticipating things has quite an important role to play.
Thank you. Yes. There is a bit more to Carmela's comment. I'm going to see if I can get into that. But in the meantime, because we are coming towards the end, does anyone else have any other questions they would like to put to Melanie, either in the chat or obviously please do feel free to turn on your sound and ask the question directly. I mean, Nisha, do you have any questions?
Yeah, I was actually just going to type a comment, but absolutely fine. Yeah, it's not really much of a question, but I just wanted to say really brilliant insights into your work, Melanie, and a lot of the stuff that you said has resonated with the research that we're doing, mainly perspectives from patients, members of the public, but also healthcare professionals on the front line who haven't yet come across AI technologies in their line of work and may in the future. But certainly a massive worry for me is we are leaving these people behind. We're not bringing them along as these technologies are coming into place. And it's sort of, I guess a really broad question would be around how could we as researchers and policymakers sort of tip the scale so that the decisions around AI are democratic. And exactly what you say is we need to bring more people to the table. And how we actually do that is an unknown sort of, we're sort of trying this, PPI approach in a lot of the research that we do, but, and the sort of clinicians that I work with as well are, have the incentive to speak to patients and, try and understand their perspectives as they design these technologies. But it's also, yes, they don't necessarily have the tools. They don't really know how to do that. But how do we get to that point where we are, democratizing this thing and making sure that all the voices are heard? And I think that's a massive challenge. The people that we speak to just say that time and time again is that we don't feel like we're being heard. The PPI work that we do, the people that participate in that are constantly trying to get into research to sort of make their voices heard. But often we are leaving a whole, group of people behind who are generally underrepresented. And it's just a real challenge to get those voices heard, I think. And yeah, my worry is that we are leaving so many people behind.
So I feel your pain. So my analysis of what the problem is that this is, well, it's what I've just said, is that policymakers and technology developers have this science to the rescue mentality, and what we're saying goes against that. And it's really, really difficult for them to hear that the technologies are problematic and that the downsides are baked in, and that you can't just take away the downsides and deal with them elsewhere. And it just goes against everything they've understood about technology for the entire of their lives. And it's incredibly difficult because these decisions need to be democratic decisions. They can't be technological decisions. So they need to be made in a way, whether they're made by, whether I mean a democratic decision in terms of opening them right up for participation, or whether they're just subject to scrutiny and subject to a process that has democratic approval and democratic credibility and accountability. I'm not clear about that, but I think there's options of how this could be resolved, but in order to get there, some understanding that these technologies aren't these solve-alls that are going to save money and produce better healthcare needs to be had. And I mean, just one personal painful example. So I've shared, and I'm happy to send you the link. I've written this as a paper, and I've put it last week on a preprint server because I keep on getting the same comments from reviewers, which is the problem's not with the technology, the problem's with the use the technology is put to. We can manage these downsides, and she's writing about something that isn't really a problem. We've learned how to deal with the downsides of technology. And so even reviewers I'm not trying to publish in science and technology studies journals because everyone understands what I'm talking about. I'm trying to publish in engineering journals, and even peer reviewers cannot move away from this science to the rescue idea. So I just kind of think that I'm onto something if they're not listening to me.
No, I completely agree with it. I think you absolutely are, because it's so much more nuanced than, right, your early slide, you said accountability, responsibility, transparency.
It doesn't come close.
Yeah, absolutely. It's just, being regurgitated over and over again, and we're not looking at the more nuanced issues, or at least, that they're not being incorporated into frameworks as they're developed at the moment. So yeah, completely agree with you. Yeah, we need a deeper thought, deeper lens with this.
Thank you. At least I'm not being boring then. Good. I've talked about it so much I can't tell whether it's interesting or not anymore.
No, brilliant.
And great questions. Thank you.
Yeah.
Thank you. So, just to round off, I think further to Camilla's message, she said there was a bit more. She was saying the evidence-based decision-making is now changed more towards evidence-informed decision-making.
Yeah.
Meaning we're not only basing our decisions kind of on evidence, on quantified so-called hard evidence, but also on human and professional knowledge and experience, which I guess is a positive step. And that potentially, I think, can certainly help if it's applied in the AI sector. But again, I think, as you said, it's a multi-level thing. There's a lot of things that need to be done. There's not, So I think on that note, I would just like to, again, thank you very much, Melanie, for giving a really great talk and for rounding out our Trinity Term Law and Technology webinar series in style. And yes, thanks. That's been brilliant. And if everyone would just like to join me again in thanking Melanie, that would be
Thank excellent. You so much.
Thanks for having me. Thanks for having me. It's been really nice.
Brilliant. And yeah, I'd love to see that paper that you put forward. And
yeah, I can send you a link now. It's in existence. I'm just ignoring the journals. It exists.
Well, you can keep pushing. I think that's the way to do
it. Yeah. Thank you. And thanks for the questions.
Thanks, Melanie.
Thank you. Hopefully, Melanie, you can see all the lovely comments in the chat for you as well.
That's very kind of you. Thank you. I'll have to download those.
Yes. Excellent. Okay, I'll stop recording. Thank you.
Thanks.
Thanks, Emma. That's great.
Yeah, thanks,